He was the brain behind, along with Sarita Bajaj, in organizing a mammoth RSDI last year at Lucknow. And in the recent times, I've been following it. Every organization, not only nationally, globally, has been endowing him and empowering him. Public congratulations for that, Anuj. Proud to be your friend. I ask Anuj to take his 5 minutes to talk on the School of Diabetes, empowering the healthcare providers.
Thank you, sir, for giving me this opportunity to speak about the School of Diabetes before all of you. Many of those who are sitting here are part of the School of Diabetes. In fact, this was the dream concern of Dr. Sadikot, who has been the president, or who is the president of Diabetes India. When he has been elected as a president of IDF, he has communicated to us that he really wants to improve the standards of the medical care of the diabetic individuals in India, and what could be the best way of doing so. Dr. Sadikot has given us the vision for the working in this direction, in which we have tried to accomplish the goal of establishing School of Diabetes, and which has been largely helped to us by another visionary of this thought. He was none other than Professor Ravi Kant, who was the Vice Chancellor, who is the Vice Chancellor right now also of the King George Medical University. And once the King George Medical University at Lucknow has been associated with this ambitious project, the two bigger things has come together, and this project has seen the day of the light. And we could find that those dreams and those goals can be achieved in better way. Dr. Jargar is the dean of that school, and Professor Nasim Verma is sitting before me. He is one of the national coordinator of the school, who is looking after the syllabus as well as the admission proceedings. Dr. Banshi Sabu, who has been the main person who has brought this idea. Actually, because of his efforts, we could really get this School of Diabetes convert into the reality. So, the concept of a School of Diabetes has arisen to make more and more people educated enough to provide good care in diabetes, especially in India. We are at the verge of being capital of the diabetes in the world. We are having 70 millions already. We are just behind China. Anytime we can cross it, but really we do not want to cross that figure, but it is a chance. In such kind of the scenario, if we shall not be improving our diabetes care, then probably this will happen at one day. We shall be crossing the number of diabetes as well as more complications in the diabetic individuals in our country, which will be much more than China. So another important thing what we have noticed while making this project, and which was also one of the important reason for that we started this School of Diabetes, we Indians are spending more on the complications of the diabetes instead of prevention. Prevention is always a bigger thing, and prevention can only be achieved when we shall motivate the healthcare givers for this direction. Keeping this in mind, in the leadership of Dr. Jyoti Dev, we started a School of Diabetes for the healthcare providers, for the peoples, those who are working in the dietitian, as a working in the helps in the clinics and pharmacists. So all those people has also been given the training of the diabetes, especially the basic knowledge of the diabetes, as well as what should be done when the person knows first about the diabetes. So with these goals we could be able to achieve, and in fact this course, which has been meant for the paramedicals in the leadership of the Jyoti Dev, has already started. All the modules has been made of this, and probably in very few days, or we can say in the 2 or 3 weeks, we shall be starting the course for the doctors also, because it is also moving very fast as far as the modules progression as well as recording is concerned. In this School of Diabetes, we have changed the methodology in the way that we are not organizing any classroom meeting, we are not organizing any CMEs, we are just giving the lectures online. On the basis of those online lectures, the person can listen, the concerned person can listen those lectures. He will be given some questions on the basis of those lectures, and those lectures and those questions will be submitted every month. So 1 month there will be the 2 lectures, and the 3rd week there will be a questionnaire to fill up, and at the end of the 1 year there will be a final exit exam on the basis of those lectures which has been provided to him. So this is the basic structure of this, and I am happy to say that Professor Sarita Bajaj is also sitting here, who is the important member of the steering committee, and Dr. Jain Panda, who is the national coordinator, I could not see you, who is the national coordinator for the course for the diabetes, which is the primary course of the certificate course for the diabetes, which have been given the name of CDiab, and master course of the diabetes has also been launched, is the name of the MDiab, in the leadership of Dr. Samit Ghoshal, and I'm looking after all the 3 courses together, and above me Banshi is the course director for everything, Dr. Banshi Sabu is the course director for everything, and I already told that Dr. Jargar is the dean, and we are following the vision of Dr. Sadikot. Thank you very much.
Now we know, this year there has been a huge talk about cardiovascular benefits in terms of liraglutide. And last time we talked about Amparag, and is it a class effect or is it a drug effect? In a similar fashion, the question is GLP-1 receptor agonists. Are they all the same? We have a guest from England, whom I have the privilege of introducing 3rd time in the last 48 hours. John Wilding is a professor of medicine at the University of Liverpool. He's trained in Southampton and Hammersmith Hospital, and is a prolific researcher, has more than 250 publications, and has a huge interest in obesity and diabetes and development of new treatments. John, would you take a few minutes to carry us through?
Thank you very much, and good afternoon. It's great to be here. I managed to slip away for a little swim in the pool, so I'm feeling quite refreshed now. So I've been asked to address the issue about differences between the GLP-1 receptor agonists. Now, of course, there are a number of these now available. We've had exenatide for a long time, exenatide long-acting for a little while as well, and lixisenatide. And now we also have liraglutide, dulaglutide, and I'm not sure whether you have it here yet, but there's also albiglutide available in the UK, and we have semaglutide coming. So there is a lot of these drugs, and they are very different. Firstly, we have to think about the structural differences. So the first ones that we had available, like exenatide, the long-acting exenatide once weekly, and lixisenatide, all came from a molecule called Exendin 9-39 that originally was isolated from the saliva of the Gila monster. Of course, it's now not produced from Gila monster saliva, it's made by genetic engineering like everything else that we use that's a biological molecule. But structurally, this is a GLP-1 receptor agonist which is resistant to degradation by DPP-4, which is the fundamental thing you have to do when you make one of these molecules. You have to make a molecule that looks like GLP-1 enough to bind the receptor, but you have to change the molecule so that it cannot be broken down by the enzyme DPP-4. When we did our very first study many years ago at the Hammersmith with native GLP-1 injected subcutaneously before meals in people with diabetes, we were only able to demonstrate a very small postprandial effect because the half-life of natural GLP-1 is so short. So you need to prolong the half-life. Now the Exendin molecule is very different from human GLP-1. It's only about 50% of the amino acids are the same. And that creates some problems in that there is a significant rate of usually non-neutralizing antibody formation, but a small rate of neutralizing antibody formation that can affect the efficacy. And the exendin-like molecules tend to be relatively short-acting with a short half-life, so that they have to be given usually twice a day, although lixisenatide can be given once a day. It's most of its effect is on the postprandial glucose. So they have structural differences which translate into pharmacological differences, which translate into differences in terms of their clinical effects when they're used in patients. If we think of the other three molecules, liraglutide, dulaglutide and albiglutide, these are much closer in their biology to human GLP-1. Liraglutide only has 2 amino acids changed, and then it has a fatty acid molecule attached via one of the amino acids, which has been changed to prolong its half-life in the blood, and the other change is to make it resistant to the DPP-4 degradation. Dulaglutide is 2 molecules of slightly altered GLP-1 linked by an immunoglobulin-like molecule, and albiglutide is bound to albumin. And each of these molecules has unique properties which changes their duration of action in the body and their effectiveness. So when you look at the effectiveness on HbA1c, the human analogues seem to be a little bit better. Dulaglutide and liraglutide, and to some extent albiglutide, probably a little bit more superior to exenatide when they've been compared in clinical trials. If we look at the weight loss effect, that's very interesting because the most potent there on looking at the data seems to be liraglutide. And in fact, albiglutide virtually causes no weight loss at all because when you bind the GLP-1 molecule to albumin, it can't get into the brain and it needs to get into the brain to produce some weight loss. So there are differences between these molecules. And when we come to the most important outcomes, which are the complications of diabetes, we're beginning to see those results emerging now. So with lixisenatide, admittedly with a different trial design and a different population, we saw no benefit but no harm in terms of cardiovascular disease. But with liraglutide, which is the more human-type molecule, we have seen very clearly in the LEADER study a reduction in cardiovascular disease. And we also know that the up-and-coming molecule, semaglutide, which is a once-weekly GLP-1 receptor agonist, which also has a fatty acid attached to it in similar fashion to liraglutide, but a slightly altered way to give it that extra long half-life, has also been shown to reduce cardiovascular disease. Although we don't have the details of that study yet, we're going to hear them at the ESD. So there are differences between these molecules, and I suspect that this will, over time, start to change the way we use them in clinical practice. I'll leave it at that, and I'm very happy to answer questions.
Dr. Sandeep is Chief of Diabetes Dentistry at Jyoti Dev's Diabetes and Research Center, Trivandrum, and is the Chief Dental Surgeon, Anantapuri Dental Care. Sandeep.
Thanks, sir. Good evening, all. First of all, let me thank Jyodev, sir, and the entire scientific team for giving me a chance to speak in front of you and to be in a panel with such eminent, famous persons. Jyodev Diabetic Center started in the year 1997, and in 2006, a dental wing was introduced. The reason behind that is simple. It's because of the association between diabetes and oral health. I've been working there for many years and have seen that over 90% of subjects with diabetes have dental issues like gingivitis, periodontitis, then xerostomia or dry mouth, greater risk of caries, opportunistic infections, etc. etc. We have conducted surveys at JDC and have found out that more than 50% of those who participated have dry mouth, more than 55% have food lodgement between the teeth, and more than 60% have multiple periodontal abscess or mobile teeth, which is actually a classic clinical sign of periodontal disease. So actually, the periodontal disease actually is the most common oral manifestation of diabetes. It's actually considered as a 6th complication of diabetes. Studies indicate that a subject with diabetes has 3 times more chance of developing a periodontal disease than in others, and if it is a smoker, the chances increase by about 4.6 times. Actually, now there's emerging evidence to suggest a two-way relationship between diabetes and periodontal disease. That is, diabetes increasing the risk for periodontal disease, and periodontal disease negatively affecting the glycemic control. That is, a periodontal disease, it increases the insulin resistance, and so it worsens the glycemic control. And when a periodontal treatment is done, it decreases the insulin resistance and improves the glycemic control. Meta-analysis indicate that around 0.4% of reduction in A1C level can be anticipated following effective periodontal treatment. So in diabetic center, when a newly diagnosed diabetes mellitus patient comes, we first tell them about this impact. We give patient education, and then we ask for routine dental examination, maybe once in 6 months or at least once in a year. If a patient is already diagnosed with a periodontal disease, then first we give, as usual, we give patient education, then we give oral hygienic instructions, and then we do non-surgical therapies like scaling, curettage, etc. And then we monitor the treatment outcomes. We recall the patient at least every 6 months. Then we monitor the treatment outcomes. And if the patient does not respond to these non-surgical therapies, then we go for surgical therapies like flap surgery, bone grafting, etc. So if periodontal disease is detected early, then we can cure it by most cost-effective measures. So what I want to say is, please assume that your patient is always at risk for periodontal disease. So always refer them for periodontal screening, and then give oral hygiene informations, and then do proper patient education. Thank you for your patient listening.
I am reminded of a very fascinating episode. Bertrand Russell wrote one book known as Unpopular Essays. And in that he writes that Aristotle had said, a few hundred years before Jesus Christ, Aristotle had said, a few hundred years before Jesus Christ, that women have lesser teeth than men. And it took more than a century to realize that we have equal number of teeth. Nobody bothered to open the mouth and look at it in a cohort of individuals. And that's human nature. Huh? That's human nature. We do all those high-tech tests, but do not ask the person to open the mouth. When I started my endocrine practice, telling you honestly, in my own institution, in my OPD, we used to have, institutions, those cubicle-like OPDs. I asked at a very big table. He said, no, patient, big. Because, halitosis used to be so common. It has been nauseating at times. Things are much better today. You are relatively more fortunate. But it used to be much worse than that today. So I'll be self-inviting one Dr. Abdul Hamid Zargar to talk on Ramadan and diabetes. First time, I was exposed to the thought of Ramadan and diabetes was in early to mid-90s. I don't exactly remember a day. There was a meeting in Egypt. And that was the first time, in the evening I was having dinner by the poolside. One thick man comes in and says, by any chance you are Dr. Abdul Hamid Zargar? And I said, how are you, dear sir? And that, dear sir, today is the IDF president. The first time I met him there during that Ramadan meeting, I believe it was 94. And two things dawned on me on that particular day. One, that religion gives a huge sanctity to the doctor to make a decision, whatever the doctor's decision. He dictates whether a person fasts or not. And that person should have no qualms. Religion, even if he is a Muslim, religion does not abstain him from making an error of judgment. If he thinks fasting is going to damage the person's body, he should unambiguously tell him that it's not. And there were ulamas there who said, religious priests who said that if this person does not listen to the doctor and dies, it tantamounts to suicide. And suicide is grossly banned in Islam. It's as good as killing a human being. So there's one thing that, dawned on me that doctor can say, no, you don't bust, you don't have to be scared about it. Second thing was, the first time, we've been advocating that till that time, most of the people would not be amenable to getting a test done. Your blood sugar done, you say it will break our fast. They said, no, any number of blood sugars can be done. Because when you do a blood sugar, you are taking away from body, you are not putting into the body. So it should be, there are no qualms about it. You get it done. So the point is that there is a lot of religious liberalism in the whole process. But our own thought process brings a lot of conservatism in the whole process. That liberalism does not get translated into the real-time practice. As will be apparent by the data that there was a multinational 12-country data that whatever you tell people, 80% of type 2 diabetics fast in the Muslim world and 40% of type 1 diabetics fast. I do remember attending a meeting in Dubai 2 years back, a fortnight before Ramadan, on Ramadan and diabetes. There was a young gynecologist from Dubai, no, not gynecologist, an endocrinologist, an American trained endocrinologist from Dubai working in Dubai. Said that in spite of the fact that I'm an endocrinologist, I had GDM and I did fast. I said, why? You do that? He said, it was looking so odd at home from the social point of view that nobody eating during the daytime, and so these collateral factors come in. Now, when you do believe that 80% anyway would fast, the next best thing that you can do is make it as safe as possible. Next best thing, that's the only thing you can do it. You see, like people who are on diet, people who are on metformin, people who are on thiazolidines, people who are on DPP-4 inhibitors can easily fast, do not have a huge SL. Now, among sulfonylureas, Arvind showed, we published some data, multi-center data between 2 centers in India, 1 center in Pakistan and 1 center in Bangladesh, that glycolazide, a stable dose, is relatively safe, no hypoglycemias. So it means that those people also can be fasting easily. And people who have graduated to insulin therapy, basal insulin therapy at that time, most of them could easily fast. And thereafter, people who get into, see, India and subcontinent is a huge premix market, which will not be true for England or United States. Basal bolus would be there. But there's another debate why we are that. We have our own thoughts on that. Even they can fast, with some changes, the morning dose getting into the evening, and the evening dose getting truncated by 50% at the time of sahur, the morning meal. But understandably, there will be a small class of people who should be vehemently told not to fast. Anyone who has some form of a renal dysfunction and has a potential of getting dehydration and who takes multiple drugs should be unambiguously told that you cannot. People who are on insulin and are pregnant should be unambiguously told that it can be dangerous to the fetus. Unambiguously and very vehemently. And people who are on, MSI therapies, 4 or 5 doses of insulin, people who have brittle diabetes, people who otherwise, prior to the month of Ramadan, have been having recurrent hypoglycemias, unambiguously told that you cannot fast. But the point is, whom does one tell all these things? When a person comes to a clinician and asks us, what do I fast or not? What precautions do I take? One. Second thing, how many of us consciously ask a Muslim patient, Haji Sahab, are you going to fast? Never do it. It's neither the patient asks nor we ask. So how does it get translated into a proper education of the patient? For decades we would see that people would make their own judgments on therapies and then land up in the hospital with the profession only when the trouble is there, either hypoglycemia or hyperglycemia. And many times, in this religious frenzy, many people would believe that they did very well with a particular regimen. They say only they took 1 tablet or 1 dose of insulin. No, whatever good or bad it did to the month of Ramadan, then they get acclimatized to only 1 dose of insulin till they have next appointment 3 months down the line. So that does more harm than what would have happened during month of Ramadan. So the only solution that we have thought, every time, we cannot see every patient with diabetes fortnight before Ramadan or month before Ramadan. So whenever this Ramadan is around the corner, 2-3 months ahead, whatever the cycle of your appointments, if you call patients after every 2 months, if you call patients after every 3 months, then start it 3 months early, because you know no one. And that should be sort of initial. See, the way we say every year you should get a lipid done. See, every year you should get a fundoscopy done. So every time, the Ramadan approach, you find out who is the potential person who is going. It's a part of that educational process. So the way we every time keep on talking about re-emphasize lifestyle if it's not controlled. So unless that is done, it's not happening. But the only good thing is that now there are lots and lots of people who are aware that people are fasting and their diabetes management needs to be customized to the fast. And we do not see the number of complications that we used to see during Ramadan. But I must tell you, there's a small subset of people who are relatively overzealous, and in many individuals, that will say about 1/4, almost 3/4 we have been able to rationalize, and with a minimal thing here and there. You take quite few months to put a person on the rails in terms of getting a good glycemic control, getting a good blood sugar control, getting some semblance of hemoglobin A1C. You know our own country, and you know us also. You face facts. Very difficult population, predominantly less educated or so, and then somewhere along, we are comfortable with 7.5, 7.3 when we have seen only N and 10, and then suddenly comes this month and comes 3 months down the line, is again 8 or 9 or 10. And with that religious frenzy, he doesn't feel any symptoms, he feels comfortable. And we are back to square one where we were 6 months earlier, not 1 month earlier. So we cannot change that whole population. We can change ourselves. So taking this responsibility, yes, if there is a patient, is a Muslim patient, depending on your appointment circle, how often you call them, start that process. And the way we keep on educating our dietitians, counselors, put this also on the roster, that this is the time we keep on educating our own patients. And I'm convinced that from my own practice for the last 30, 40 years, 70% people can very easily fast. Now, on the one hand, some people want a scapegoat. Somebody, Doctor Sahab, I have diabetes, so I can't fast. No, don't give him that latitude also. You tell him, from our point of view, it's okay. No, this is another class. But it's another class, whom we vehemently want not to fast, they are fasting. And those who can easily fast want to find a way out by asking the doctor. Thank you. John, now we will have few questions. And for starters, I was really wondering, you talked about leader a couple of times in the last 2-3 days, and when last time we started talking about Amparag, then people always started talking about, is it a class effect or is it a drug effect? And the same word has started already happening with liraglutide. Is it a class effect or is it a drug effect? Your thoughts on that?
Yeah, well, so the question as to whether it's a class effect or not, we honestly don't know. We've got other trials that we'll report in the next couple of years. So there is a trial with exenatide once weekly, which may be different from lixisenatide. It's a different design of trial, and the once weekly exenatide is quite a potent GLP-1 receptor agonist. So we wait to see the results of that. We also have trials ongoing with both dulaglutide and albiglutide. But until we see the results of those trials, I don't think we can be sure. We do know that the SUSTAIN-6 trial, which I'm an investigator for with semaglutide, is positive, but we don't know the detail. But that at least suggests that it is true for more than one drug in the class. But whether it's true for the whole class, I think we have to wait and see.
Anuj, when do you think that we'll start enrolling the first batch of these students, enrolling them for our own certificate course and degree course?
I think next month we shall be able to enroll. In fact, we have started the enrollment, and next month we shall start the first batch of the course of this School of Diabetes, especially the certificate course. Master course is also ready, and people are also started to be enrolled in that too. And the earliest one, as I already told before, that will be coming of the DDAB, and that is for the diabetes educators. And diabetes educators course is being prepared and taken care by Dr. Jyoti Dev, and it has already been completed its enrollment, and most likely it will also be started from the next month.
I must tell you, it's a huge transition the way people look at diabetes. I'll tell you, when I started my endocrinology, the premier institute of All Institute of Medical Sciences governing body did not find it justified to start a postdoctoral course in endocrinology. So the only course available in this country was at PJ. And John, would you believe it, in this whole country, there was one seat for endocrinology to compete for in 1983. When I first time attended a meeting of RSDI, it was supposed to be a research society, genuine research society, in February 1984, in Institute of Medical Sciences with Dr. Ahuja. There were 7 of us sitting in a room. And last time I delivered an oration to Delhi branch, there were 750 people interested in diabetes. I gave an oration in Bangalore, there were 3,500 people. So I'm so delighted that we have dynamic people like Anuj, like Bansi Sabu, and like Dr. Verma. I must tell you, whatever the other names, they are collateral names, and their fundamental role is facilitatory and advisory. But the groundwork these guys have done along with Jyoti Dev and Samit Ghoshal. So I think now the baton is passing in the right hands, and diabetes management is gathering the momentum that we generated when there was no justification. When I started my endocrinology department, our own governing body said, why do we need this apart medicine? You have to write 2 tablets, and why? So it was a huge hassle fighting out to get a department, but now getting courses and getting some, and today, from that one postdoctoral seat, today we have 55. In the very institution which refused to have a department, today we have four postdoctoral seats every year for endocrinology. So this is a sea change and commensurate with the requirements in this own country. Getting on, Sandeep, do you think, we have guideline, we always believe in, whether we believe it or not, but we always talk about ADA guidelines, ESDA guidelines, RSDI guidelines, blah, blah, blah. There aren't any recommendations from these ADAs and ESDAs about dental health. Because, I tell you very honestly, I mean it when I talk about that big table and that halitosis, becoming an issue, to be as far away from and it's becoming much lesser today. As a part of it, overall better care available, and but still is a huge issue. I used to tell in my STS people that, if you have 100 crore patients to take care of, dental surgeons have 32 crore patients to take care of. Everybody's teeth are the way they are. Any recommendations, routine annual checkups or something for diabetics?
So as such, we recommend checkup once in 6 months, or at least once in a year, based on the oral hygiene of the patient, actually.
Any questions on? Please.
Sandeep, important question to you. Now it is said, and in fact few of the authors has started saying, it is not only that, it is not only good to say that periodontitis is the 6th complication of the diabetes, but the periodontitis can give you an indication that this person is going to have diabetes. It can preempt the diabetes. What do you think about? What is your experience in your own clinics about this?
Yes, sir, definitely. When patients come to us and we see periodontitis, first of all, we ask them to check for diabetes. So it can be said as before, we can say it detects actually diabetes.
Is it possible that the person who is getting periodontitis today, will he be diabetic after 5 years or 6 years? And if it is yes, then what is the connection between these two?
Actually, recent studies indicate that periodontal disease can transform into diabetes.
Yeah.
It's because of the
I want to know that what is the
mediators.
pathogenesis connection between
So because of the release of inflammatory mediators, there will be increased insulin resistance, and so the glycemic control will be worsened actually.
Speakers, thank you so much.